Welcome to the Smarter Systems Better Here podcast. And my name is John. I'm your host. And to join us today is Dr. Michael Liebman. He's the managing director and founder of IPQ Analytics, and he's a global expert in disease modeling and patient-focused analytics dedicated to transforming drug development and healthcare through deeper understanding of real-world disease complexity. So thank you for joining us today, Dr. Liebman.
Thank you for the opportunity. I appreciate it.
Absolutely. And just to get us started, can you tell us a bit about your background, your business, and clients that you serve?
I started out as a theoretical chemist and a protein crystallographer, and I have a mixed background in academics for a number of years, then into industry. The last position was global head of computational biology and genomics at Roche. I went back to academics and then was recruited to run a breast cancer center sponsored by the Department of Defense jointly with Walter Reed, where we worked from the clinic back, from surgery, pathology, tissue banking, genomics, proteomics, and informatics. What I've launched with IPQ Analytics is a modeling as a service group that works internationally. We work with pharma and biotech and healthcare systems, but we also work with government agencies internationally, and we work with payers and investment banks, actually. One of the things we've launched just within the last year is a nonprofit that's focused on the issues of women's health called Woven.
Woven, excellent. And do you mind just telling us more about Woven? Sounds like an exciting thing that you're getting started. So
yeah, we decided to create a women's health focus in the nonprofit because, of course, it's an underserved area in general. But I wanted to be able, based on the modeling that we've done and the methods and so on, and the challenges we've seen, to be able to do it with what we thought is the best way forward. Not necessarily focus on an immediate revenue stream, but really trying to find out what are the root cause issues that need to be addressed. And part of that is understanding actually how a woman undergoes physiologic development throughout her lifetime, how that interacts with certain conditions, and also environmental and lifestyle interactions. But what we've done is decided to focus on two specific areas, one being infant and maternal morbidity and mortality, with a specific emphasis on things like hypertensive disorders of pregnancy, such as preeclampsia. And then the other is that women actually go through perimenopause and menopause individually, but there are some common patterns that they follow that we don't actually understand as yet. And to help them better guide that transition, as well as understand their individualized risk for breast cancer or cardiovascular disease or osteoporosis, we really need to take different approaches than we've done in the past. It's not just an issue of femtech, it's an issue of fem health.
Exactly. So you're trying to find novel, new ways of approaching the source of the issues at hand. So,
well, the very first step is figuring out what they are, and then
what they are exactly.
Yeah.
Mm-hmm. Yeah. And then it sounds like part of what you're doing too is like once you figure out what those are, then you can make, like you said, models as a service to predict those things based upon specific data points they're looking at. So
and we both look at the data that's available, but we don't limit our work to the data that's available, because if our models, we try to build our models to represent the complexity of the real underlying problem, the root cause issues. And that comes from talking to clinicians and to patients as well. Right. And when we build those models, we build them independent of whether the data is available. And then we look to see what data is available. And in fact, when data isn't available, we've initiated studies to collect that. And we're currently collecting that in several international locations, because we do a lot of work with underserved populations as well.
Excellent. So it's truly like an international effort is what it sounds like. And then as far as like the focus of IPQ Analytics today, what kind of role are you playing in driving the growth? Like where are you trying to go right now?
Well, I've basically surmised from having worked in about 20 different diseases, we find that physicians have to be very operational. They don't have the opportunity to necessarily address the questions that are maybe haunting them, but they're not given the opportunity in treating patients or to have the resources to actually go in and do the real critical research, try to look at root cause issues. To us, one of the root cause problems that's shown up in almost every disease area we've worked in, is we tend to have a relatively coarse definition of a disease. We don't really have adequate subtyping, classification, and diagnostic criteria. And that is going to impact not only how to manage a patient, determine what testing or what drugs to use, is going to impact drug development, is going to impact reimbursement and what a payer does or policies. So we view enhanced stratification of the patient and of the disease, but working in the environment of how medicine is actually practiced as really representing the complexity of the real world.
Yeah, so you're really taking like a holistic view, talking to the patients, talking to the providers, talking to the payers, and then really taking not a subjective look at it, but an objective look as much as possible in order to get the most precise data available to you to then to enhance your predictive modeling capabilities. So it sounds like.
Yeah, we're trying to move from correlation to causality.
Yeah.
And it's a big hurdle, but we think we really need to try to drive as much towards causality as possible, because that's really what you need to be able to impact the practice of medicine.
Absolutely.
And improve outcome.
Yeah. And then like kind of getting more of the industry, because we're kind of on that topic anyway, like what's one shift in your industry that you think most like founders, operators are underestimating at this point? I'm just curious to get your take on that.
Well, I think they're underestimating where we actually are in our knowledge. When we're using things like ChatGPT and large language models, things of that nature, we're dealing with the knowledge that's currently available. We're dealing with models that are currently available. We're dealing with diagnostic criteria when we're trying to use AI to be able to use that as a guideline for where we want the AI to help us. But what we really need to do is go much more deeply into, are we actually curing the patient? Right. We know how to develop drugs, but are they actually treating the disease? Are they producing the outcome we really want? And also, are they, it's not just who should get a drug. We also should be focused on who shouldn't get a drug, because getting a drug that's not appropriate may end up causing more problems downstream with less options for how to actually address the condition the patient now presents.
Yeah. And then like, how do you see like the industry adapting to like what they're underestimating? Like, how do you see them adapting to that? Or are they not? Are they just?
Well, I think we have a little bit of a challenge in that there's a lot of hype about what the AI can produce, and also taking advantage of all the literature that's available. But we also have to take a deep dive into what is that literature that's forming our large language models, or things like ChatGPT and so on. When you look at the literature that's publicly available, open source and so on, things like ArcIV, you end up with millions of papers that provide scientific basis. But if you actually go more deeply, you find out that probably less than 40% of them ever get published. So the fact that they're publicly available and they have some data doesn't necessarily translate to the quality that you need. And it's really a concern of the quality of the data. The other thing that we're looking at is we work with knowledge graphs, and knowledge graphs are attempts to really integrate and make accessible through agents and other methods all the knowledge that's currently available. But again, it's the knowledge that's currently available. It's not able to necessarily identify what are the gaps in that knowledge. How do you build a model to know what's missing in that knowledge, or where there's conflicts, and how can you possibly try to resolve those conflicts? So what we've been doing, because there's an incredible amount of effort in building these knowledge graphs and putting together the ontologies from a lot of different resources to make them accessible, what we're trying to do is build a layer on top of it to also make it actionable. So what are the things that need to be pulled out? What are the questions that need to be driven, that we have to look for answers for, to make it actually actionable in the clinic or in the laboratory, in the research environment?
Yeah. So you're trying to look at these models from like a big picture perspective, trying to evaluate the quality of the data that it's digesting, and looking at the outputs of that data. Like, for example, ChatGPT putting in an input, a prompt, where is that data querying? Where is it coming from, right? Like evaluating the quality of the data. So Yeah, that definitely makes sense, and people should think
Yeah,
about
I
that.
can give you, an example. One area in some of our projects, there's a lot of emphasis on social determinants of health.
Hmm.
And it's in a very, very important area, not any way to discount it. But the tendency with social determinants of health is to look from the outside in and say this is the level or the standard that you would expect should be achieved. What you're not really dealing with is the fact that you may be dealing with a population or a culture group for which they have different priorities. And
Right.
those priorities may not align with what you think are the guidelines. And not only may they have different priorities for cultural reasons, they may have other differences because of trust issues. So we've worked with a number of immigrant populations. I mentioned we work with underserved populations. The idea that people shouldn't smoke, everyone understands that from a health perspective. But in a culture where smoking is part of a religious ceremony, they probably don't even
Yeah.
consider that smoking.
Yeah.
And
Perspective.
and in terms of trust, we work with immigrant populations. If they came over under stress, political stress, that's different than if they came over for family reasons or to improve their economic status. And they'll have different relationships with the government, with how things are going to be perceived. So that just shows you the need for expanding our view to incorporate the real complexity of what the world contains.
Yeah, absolutely. And then just kind of how are you adapting, like in your own business, to this, shift where, or I guess you're trying to shift from? How is that affecting how you're, working in your own business?
Well, again, that's one of the reasons we set up Woven as a nonprofit.
Yeah.
So, what we do in IPQ is we work with pharma, as an example, to address possibly failed clinical trials, to help them understand what real world data really means, not necessarily what some of them think it means, the
Right.
limitations of certain kinds of data like claims data and things of that nature. And we build tools in that domain, and then we can apply them in Woven to the problems that we want to look at, but we're not driven by a very short term perspective. So,
Mm.
as an example, in our effort to model how women go through perimenopause uniquely, we're starting all the way at puberty to collect data. We want to understand when they went through puberty, weight changes, environmental exposures. We have a very detailed history of their pregnancies, things that actually aren't existent in current databases that are in our
Yeah.
model, because we understand that they would have potential physiologic impact on things like perimenopause and then therefore on risk for breast cancer. So what we're doing is, and using the knowledge graph model, enabling us to continue to expand our view, even when the data is not available, but know and use that also as a template for what data should be collected, and working with people when they're setting up new studies to know what data is of value to collect, not just what data have we collected in the past.
Yeah. So there's a lot of you're recognizing the immediate what you think might be the issue, but you're diving deeper to truly get to the source of it.
Right. We don't want to limit it just on the surface question.
Right. And then as far as like kind of looking at like your systems, like your outreach for your business, like are there any parts of like your workflow, for example, like when you're reaching out to people trying to tell them about what you're doing, that you wish ran smoother? So some of the things are like, your sales processes, intake, follow-up marketing. Is there any of those things that's where you kind
Well,
of struggle to get your message out?
we've been fortunate, I think, this year, given about 15 different presentations, and we also
Yeah.
publish. So, and we have podcasts, a
Yeah.
couple of podcasts. So we've been using that kind of mechanism. The challenge is that what we're talking about is trying to increase the transparency of the complexity. And one of the interesting comments I get when I've gone into pharma after we spend maybe an hour or two working through the problems to understand what their problems are or what they think they are. When I'm ready to leave, frequently the comment I get is, you made this more complicated than we thought. And what I have to explain is I didn't make it complicated. It is complicated,
It is
You tried to
complicated.
make it simple and it wasn't working. So I'm just exposing the complexity. I'm not going to tell you we can solve it all. But
Right.
when what you're doing doesn't work, you need to know what other factors might be critical that you haven't incorporated to understand what plan B should be.
Interesting. Okay. So you're using like kind of reaching out through like your social channels to get the message out of this
Yeah.
is potentially an issue, but you, it's interesting they see you as complicating, but you're really just bringing to light the pieces of the puzzle. So,
Yeah. And I've, in terms of our menopause study, we've been holding public forums where we invite women just to come in to discuss what are your questions about menopause,
yeah.
because you're not getting them answered by your gynecologist. And I'm not going to tell you we can answer them all, but we want to know what your concerns are. And we're finding out some interesting things that we wouldn't have anticipated and are sort of buried in the background, shall we say. We're finding that the symptoms of perimenopause can sometimes be confused for other diseases,
Yeah.
and therefore a woman may be treated for a disease she doesn't have when she's going through perimenopause, because the physician doesn't incorporate that into the treatment and diagnosis.
Yeah. To give them a fuller picture of what could be going on
Right.
below the surface. Right. So, yeah.
Well, if a woman is, on average, it takes 7 to 10 years for a woman to go through perimenopause. And there's a whole host of about 60 symptoms, some of which
Okay.
she'll have, some of which she won't have. There's a different, one of the things we're studying is what symptom did you have, but in what order did they occur, and which ones occur together? And we're using that to help stratify how a woman is progressing. But the reality is, wherever she is in that path, she's going to have other diseases that present.
Yeah.
And her status in her perimenopause is going to impact the diagnosis and the treatment response for those other diseases. So it's really a critical thing to be able to understand the whole patient, not just the fact that they're coming in complaining about a respiratory problem or fatigue or something like that, without understanding the full package, so to speak.
Right. Exactly. And then if someone wanted to come and purchase your modeling as a service, how does that look like? Or is that something that you're offering at the moment?
Well,
Because I'm
we
sure.
do the modeling as a service. We do it a couple different ways. One of the ways we do it is, it's a project-based
Yeah.
opportunity. And so we get engaged as a project. The group we're working with has the opportunity with that. They could do it as a proprietary project or a non-proprietary project. If
Gotcha.
it's
Okay.
non-proprietary, what we'll do is continue to evolve that model after the project is actually done, because it's still our model. If it's
Yeah.
proprietary, then they own and control that. But in any event, we are going to continue to refine it, because we have an underlying, using the knowledge graph approach, we have an underlying model of the disease process in general that gets applied as a background to any disease. And that allows us to continue to evolve that model based on working in a specific disease. I've worked in about 20 different diseases over the years, and this model's come out of all of those. It's a
All that work
collective
and
model.
effort.
And so that's typically how we do some of the modeling. It's one or the other, project-based, or that's how we've evolved it. There are some projects we've taken on besides women's health that I described. We've initiated some projects in multiple sclerosis and traumatic brain injury, heart failure. So we've looked at a number of different conditions where we've tried to test out how the model evolves and
Yeah.
what the needs are. But it's a continually evolving model,
Yeah. It
growing
sounds
model.
like it. Yeah. It's growing, and I'm sure it takes like many years of data to really hone in and get it not perfect, but to a point where it can be trusted. That's probably the ultimate goal.
Well, yeah, I mean, at any stage, it can be trusted based on the data that's available.
Yeah.
The issue is, it's like when you put together databases and you link ontologies, okay? A lot of that's being done by data scientists who don't understand that the data field label has a lot of context behind it that isn't being incorporated. So the fact that you have some measurement, and one of the measurements I use is glomerular filtration rate as an example, that measures kidney function. And to actually measure that accurately, you would put the patient in the hospital to measure the fluid intake and fluid output. But that's
Yeah.
inconvenient. So we have what we call estimated glomerular filtration rate, EGFR, is frequently reported based on your creatinine levels and some equations. The challenge is there's 5 different equations to compute that because there were 5 different studies for 5 different reasons, and those equations aren't equivalent.
Right.
But the annotation doesn't tell you what equation was used. And so you have EGFR, but you don't know when you're combining 2 databases, or even within the same institution necessarily, if the test was done the same way. There's the same kind of problem we have, or situation, not problem, with triple negative breast cancer. We're looking at ER, PR, and HER2 levels, but we tend to dichotomize those as positive and negative. But it depends where you set the threshold and what test you use as to what the positive and negative assignment may be at one institution versus another institution. And what we're doing is developing methods to avoid that, to actually go into a much more quantitative definition of those conditions.
Yeah. And that can be, sounds like very complicated to navigate too, because no one's doing it the same way. It's kind of like the ongoing problem in healthcare. One hospital may be doing this exact same thing a different way, right? And that's probably what you're discovering through the testing processes of these different diseases, trying to figure out what are they doing differently, and then how is that affecting the results.
Well, and I can give you a very simple example that I'm sure you've encountered. In our work in infant and maternal morbidity and mortality, where we're looking at preeclampsia, hypertension is one of the hallmarks of the disease. But the diagnosis of preeclampsia doesn't start till 20 weeks of gestation. And what we're interested in is understanding well before that if a woman has that risk or starting to present. So as we started to look at underserved populations, we were doing some studies with Morehouse School of Medicine. I realized that in general, hypertension is different in different population groups. It's associated to be different. So we started to look at hypertension and we realized when you go in to have your blood pressure measured, you're taking one value. And probably what happens, and we know what happens, is the guidelines are not actually being followed by your physician or the nurse in accordance with what the AMA has specified as a way to measure your blood pressure. But what's even more confounding, and so the simple instance is you'll walk in, the nurse will measure your blood pressure, you may a few minutes later have it remeasured by the doctor, and it's not the same, okay? Which one's correct, okay? But what's even more concerning is your blood pressure varies in a circadian pattern about 20% over the course of the day, and you're taking one measurement to approximate that and making decisions based on that. So that's the kind of thing that we're trying to uncover, make transparent, and see if we can show the value of making a change in how we're doing some of these simple measurements and the approximations that they're giving. Not that they're wrong, but they're not adequate to really define what the question is we're trying to answer.
Yeah. And it's like a bigger issue of, I'm sure why you've had to work in this, going through all these different diseases, trying to figure out, and is there like trends that you're seeing over time with these, or is it the same issue just in another disease? Just curious about that.
Well, that's how we built the common model. We find the same issues that
same issues.
They go, yeah. But when we do find a new issue, using the knowledge graph approach, we can quickly incorporate that into our model. So that's why the model continues to evolve. But, it's like dealing with comorbidities. We think about comorbidities as what condition do you have at the same time. But we also have to think about what conditions did you have, because they may have left a mark either because of the condition or the treatment. And what conditions might you have that haven't even been diagnosed yet? And so it's a more complex question than just what are your comorbidities.
Yeah, absolutely. Thank you for your time today. I really appreciate it. Definitely got me thinking very deeply on things. I'm going to probably be reading afterwards. So thank you for your insight on the data and the models and things that you're working on. I really appreciate your time today.
Yeah, thank you.
Yeah. And where can people find you if they want to reach out, connect?
The easiest way, my email is michael.liebman, Liebman, at ipqanalytics.com. IPQ is identify, prioritize, and quantify.
Interesting. I did not know that. Thank you. And appreciate your time once again, and have a great day.
All right. Thank you.
Thank you.